Good afternoon, and thank you for joining us for the PartsSource Executive Webinar. Today's presentation, Longitudinal Analysis of Cost, Quality, and Efficiency in Clinical Engineering, will be presented by Phil Satimi, President and CEO of PartsSource. And now I have the honor of introducing today's presenter, Phil Satimi. Phil joined the PartsSource executive team in 2014 as President and CEO with extensive background of success and achievement in the medical device and healthcare IT industries. Formerly, Dr. Satimi was the Chief Marketing Officer and Senior Vice President of Global Marketing and Corporate Development and Company Officer at Hillrom. Prior to Hillrom, Dr. Satimi led the Medical Device Strategic Business Unit at Hospira and served as General Manager and Business Leader at GE Healthcare IT. Throughout his career, Phil's worked with leading academic, integrated delivery networks, and community-based hospital customers to deliver technology-enabled products and services that improve the safety, operational efficiency, and clinical efficacy of those organizations. And Phil, I'll hand it over to you.
Great, thanks very much. Thank you everyone for spending part of your day with us, either afternoon for those of you on the East Coast or morning still for those of you on the West Coast, as we have many participants today. Today we're going to talk about an approach that we took initially in the 2014-2015 window and have then validated over the years subsequent to that initial finding, really to understand where spend anomalies are taking place within healthcare facilities, what's causing them, what can we do about it, what's the impact if we can fix them. We'll talk about areas where we've identified opportunities for significant cost savings, for significant process efficiencies, and importantly, significant quality improvements as well. As I mentioned, we began the study in the late 2014, early 2015 time period, and we were working with 5 hospital systems at the time who collaborated with us on a data analysis study, and we found a number of interesting initial observations. One, hospitals were managing in excess of 200 supplier relationships, but upwards of 1,000 supplier relationships to support their in-house clinical engineering programs. In many cases, we were identifying significant price inconsistency across those supplier relationships with respect to what their expectations were. And so we wondered what the cost of those price inconsistencies were over time for the health systems. 2, we heard through a lot of qualitative feedback that the sourcing through reconciliation time spent by clinical engineers, their staff, as well as the finance and AP functions consumed significant energy, with many folks quoting us times in excess of 50 minutes per order, where most of those orders were bought infrequently and were priced relatively low. Third, there was significant variance that we saw in the data from just those 5 health systems on the use of OEM versus aftermarket or generic or non-OEM products. And it seemed that there was little product quality data driving the decisions at those facilities. And lastly, we saw that the organizations had little monitoring of logistical or quality errors or defects that were coming back from the orders that they were placing and or the supplier vendor community that they were using. So overall, we saw significant diversity and fragmentation of their supply base. We saw significant price inconsistencies in the work that was being performed amongst those entities. There was significant time being spent, wide variance of product utilization from OEM to non-OEM, and little monitoring of the impact of delivery, logistics errors, quality errors. And so we set out, following that initial study in 2014, 2015, and began to look at some broader research questions. So one, if we looked at a much larger data set, would it help identify drivers of waste effectively in the form of cost, quality, or productivity waste? across the healthcare industry? 2, are these issues generally avoidable or unavoidable? And 3, what's the clinical, operational, financial impact of these issues? And those were really the 3 primary questions that we sought to answer. Along the way, we had developed 3 primary hypotheses. So 1, there are diverse hospital supply chains. They do create a lot of stress and strain to manage a high transaction volume environment. And as a result, there are potential for significant order pricing errors. And there's also a setup where you're potentially spending a lot of time and manual energy on orders of relatively small dollar value size with little reproducibility to put systems in place that would make automation easier. Our second hypothesis was that given that there was little industry-wide product outcome data and there was little use of clinical decision support systems in this area of the hospital, it would limit hospital systems' ability to standardize product decisions and therefore standardize utilization. And then lastly, the products that are required here obviously are in support of mission-critical clinical equipment and ultimately clinical access to these devices to treat patients and create better patient experience as well as patient throughput in hospitals is significantly impacted by long lead times, quality issues that we believe were not being tracked effectively in hospitals, and what, if anything, could be done about it. So the methodology we used to look at this problem in more depth was really based on 3 different approaches. The first was to partner with a broader set of hospitals and leverage their data to dig into the same research questions we looked at in that first study from the 2014-2015 time period. And we did that. We partnered with 97 health systems across the US, representing roughly 110,000 beds. And for those of you that aren't aware, there's about 800,000 licensed beds in the country. And so we had a nice sample size, roughly 15% or so of the total sample beds in the US, representing nearly 50 states. And we had this data going back since 2015. We had a second set of studies we did, which were time and motion studies. These were done on site. And then we had a third study that we performed, which was based on our own data warehouse, representing over 2.5 million transactions going back to 2008. And within those, we sought to establish a couple of different baseline understandings. So one, from the customer and provider data, what does a typical order profile history look like? How often are they ordering? What's the average unit size? What's the relative frequency of those orders? 2, what's the degree of price variance experienced across those 97 health systems? And what's the general mix of OEM versus non-OEM price utilization? In the time and motion, we sought to understand the average time consumed for product identification and sourcing. So, effectively, how much time are people spending on the orders that we just identified in the category 1 above? What's the average time for product ordering and reconciliation? And then what's the total average time for product sourcing through reconciliation in minutes per order? And then lastly, from the data warehouse, we wanted to look at issues of quality versus price trade-off. So whereas above we looked at the average mix of OEM versus non-OEM, here we wanted to understand, was it worth it? Were there significant cost savings available or not? And what could be done about it? Second, what's the impact of product quality defects to clinical operations in terms of days of additional downtime? And then lastly, what is the impact of logistical defects and delays to clinical operations in the form of additional down equipment days? So let's move into the results phase here. First, and this again reflects the profile of an organization's orders. So really we start to understand, what do the typical orders look like? What are we really managing here? What are hospitals managing on a day-to-day basis across a year? So what you see here across the 97 health systems representing roughly over 100,000 beds, they were managing on average just over 200 suppliers, and those that were over 1,000 beds as a health system were managing on average 300 suppliers. But as you can see there, that span was quite wide, and you see, the max numbers that we saw were over 1,000 different suppliers that required management. So certainly a complex and fragmented universe to manage from health system to health system. Second, over 88% of the orders were under $500 per item, and over 95% of the orders were under $1,500 per item. So you've got a lot of vendors to manage on orders that are relatively small dollars in the context of broader hospital spend. And as you can see there from the last bullet C, the frequency of reordering that same item was quite small. And so as you can see there, again, over 80% of the orders were on items ordered less than 5 times per year. So whereas you think you might be able to establish good processes and procedures for reliable and reproducible ordering, unfortunately the order set, or the items that required to be ordered, simply aren't ordered that often. And so you have a very long tail of orders that are independently each of a relatively small dollar value across a very wide segment of suppliers. So certainly a difficult situation for supply chain organizations, a difficult situation for clinical engineering organizations, neither of whom really are built to spend their days doing this kind of work. It takes very specific processes and practices to manage high volumes of low dollar orders across hundreds or thousands of suppliers. Most hospital supply chain organizations are built largely to buy capital and or high volume reoccurring items from their GPO or via exchanges like GHX. Unfortunately, a lot of this order profile work falls well outside of that scope. It's neither capital, nor is it high dollar, nor is it bought through a GPO or an exchange, EDI-based exchange. And so you're really down in the long tail of order management. Next, we set to understand what kind of price variance, if any, folks were seeing in this larger sample size. We had identified this as a potential error and risk in the smaller sample size. And so much to everyone's surprise, as we looked through the data, 90% of the health systems that we evaluated were experiencing multiple different prices for the exact same good, or the exact same SKU, stock keeping unit. So significant exposure to all of the health systems nearly. But we then asked, were there differences between the health systems? If you identified an individual SKU, and as you can see in the lower left-hand corner, we picked 20 SKUs. We looked at, on average, how many different prices were seen. And so what you see there is a single product, in this particular case, where the customers on average were seeing anywhere between 10 to 30 different prices for that SKU across each of those customers. And so in total, you were seeing 300 different prices effectively to that common pool of customers, where again, on average, 40 or 50 of those customers were seeing 20 or 25 different prices each on that individual, on those individual products. So significant variation between health systems, looking across multiple different SKUs. Again, on average, there you see 50 different customers experiencing 15 to 20 different prices on the same SKUs. On the right-hand side, we look to understand, well, that may just be between health systems, but maybe those different health systems had different prices. So what if the same health system, we looked at an individual SKU, but we narrowed it down to a single health system. And there, we picked out a sample of, in this particular case, it was a probe. And you can see there that the colors there represent different vendors that were used. The price points there are across the x-axis, and the number of purchases made at that price point along the y-axis. And so this is an item that was ordered roughly 70 or so different times across the year from roughly 4 or 5 different vendors, where they paid, again, roughly 15 different price points. And what was shocking, of course, to us is just the variance in the spread here is substantial, thousands of dollars per transaction. I think when we added it up here, even if they just bought at the median price, there were tens of thousands of dollars of savings. And again, a lot of this is not nefarious. It's just simply the processes are not in place to manage a diverse vendor community with, in some cases, a widely ranging spot market for pricing, and to be able to understand and compare and contrast the quality performance, logistics performance of each of these suppliers, so that not only are you paying the same price, but you're getting a consistent experience along the way. And what we found was just the opposite. The vast majority of health systems are experiencing price variability. They're experiencing additional variability if you look at individual SKUs across health systems, and they're experiencing significant variability on the same SKU within health systems. So overall, you've got lots of small, unrepeatable transactions with significant amounts of price variability. We then looked to understand how much supply chain variation as it relates to OEM versus non-OEM or aftermarket / generic product. And what you see across the large sample size is the left-hand data, which is the mean and median were pretty close to each other. So about 75% of the products coming in were OEM, 25% were non-OEM, but you saw significant span. So at the bottom there, 54.5%, upwards of almost 99% of the product being OEM. And so therefore, some customers are roughly 50-50 OEM to non across that community. And we decided to take a look across one of the health systems to see if there was consistency, at least at a health system level. We knew there wasn't good consistency at across the U.S. health systems, between health systems, but what about within? And as you can see there, there are a few clinic data here, but if you take out those first 4 lines, which are all clinics, and you start with the hospitals, you see that the hospitals ranged anywhere from 32% OEM at a hospital level, whereas on the left-hand side, it's at a system level. At a hospital level, 32%, upwards of 93%. And so, again, significant variability of OEM versus aftermarket usage, again, on the left-hand side, between health systems, and on the right-hand side, within health systems. And we were, again, really struck by this notion that you've got small, non-reoccurring orders with lots of price errors and variability, and apparently, no good methodology about when to use OEM, when not to use OEM. And that led us into really the next phase of the study, which was all of that is generally speaking bad news. Certainly, if you're a supply chain leader, thousands of paper-based orders, which are for small dollars, with significant work involved in order entry, order management, order reconciliation, where oftentimes your prices aren't accurate in the first place. Some hospitals are taking advantage of generic products, but it doesn't seem to be a rhyme or reason about when or why. All of that would be just bad news if you weren't spending a lot of time on it. And unfortunately, in the next phase of our study, we executed 3 different time and motion studies with hospitals to help them understand what their own processes looked like. We did this on site. We looked at 6 functional areas that contribute to the sourcing of a mission critical medical repair part. And we provided person-to-person shadowing to monitor each of the tasks, where each of the tasks was observed and then timed. We completed those 3 studies over the course of 2 years. And you can see in the lower right-hand side, they break down into sourcing and parts ID, work order data entry, PO data entry, order placement, order follow-up, and accounting. And although you see some variances from large IDN to mid IDN to academic in terms of where they spend relative amounts of time, the averages all were in the same ballpark. And so the average across this particular group is 80 minutes. We've subsequently validated this with hundreds of other health systems around the country who feel like this data is representative of their processes before undertaking a re-engineering of their process or a transformation of their approach to this. So unfortunately, the bad news goes to worse as it relates to organizations who are actually spending significant amounts of time in this process. We spoke a moment ago about the mix between OEM and non-OEM, and so the question is it worth it? And the short answer is yes, but you have to know where to look. And so we evaluated, in this particular case, over $1 billion of spend from 2 million different orders in our data warehouse. We then merged that data with supplier quality information. And so in our business, we track the quality outcome of every single product that's ever been shipped through its warranty period. So whether it was an out-of-box failure or dead on arrival, all the way through its survival of warranty period, all that information is tracked down to a transaction level. So in this particular case, we looked at on the y-axis, the vertical axis, savings rate over the OEM. And you can see those levels there are quite significant, 40%, 60%, 80% savings over the OEM. On the right-hand side, and the right-hand axis, lower axis going left to right, we looked at impact to quality return rates. And so on a relative basis, compared to the OEM original, how much incremental return rate was there? Or in some cases, if you're left of 0% or negative, how much better did the product perform actually than the OEM product? And as you can see there, there are distinct product segments. So these aren't SKUs, these are large categories of products that represent very significant cost savings, where the quality impact is negligible or statistically insignificant, and in some cases better than the OEM. But what we found is that really we were working with billions of dollars of spend data and 15 plus years of longitudinal or historical data on supplier quality performance. And so we didn't find this in many or really in any of the provider organizations that participated in the study or subsequently that we've worked with since then. So great savings are to be found and to be had, but you have to have the tools and know where to look. We then looked at the issue of product quality defects to clinical operations. And so could data help procure products that work the very first time? I mean, that's really the fundamental research question that we were going after, which is if you had good information, could you use that information to incrementally buy from people who are more reliable over time? Again, to our surprise, this is not always just an OEM answer. There's a lot of non-OEMs that represent good options, but again, you have to have the historical data to support this. And what we did in this particular study is we looked at two different populations of orders across many years, and we looked at one that had no algorithms applied or decision support technology applied to find the best supplier based on historical quality data. And we had another group that was using decision support technology, which was an evidence-based algorithm that looked at all the historical data and said the best provider of this SKU in the country or the globe is this supplier. So not the product category, not the product modality, but the individual SKU, who produces that SKU best and delivers that SKU best. And what we found is that the quality coded return rate, when that algorithm was applied, showed significant improvement over those orders that did not have it applied. And as you can see there, we began applying this algorithm technology to this batch of orders back in the 2011-2012 timeframe. And as you see, a significant serial reduction in quality coded return rates to now well below 1%. And the potential impact, if you evaluate that difference between a return rate of over 3% versus a return rate of less than 1%, represents roughly 30 additional days of clinical operations impact per 1,000 transactions. So the question of, well, what's the relevant number of transactions? What we see is that a 5 to 10 hospital IDN might have in the range of 5,000 to 6,000 transactions per year. But certainly your MMIS or CMMS data would likely be able to tell you how many work orders were performed, how many of those had associated parts, or your ERP should be able to provide that information to you. And so by using an approach where, again, evidence-based algorithms are applied, you can improve additional days of what would have otherwise been downtime, effectively by avoiding products that we know cause quality defects. And as a result, rack up additional days of downtime because you receive a product that either is DOA or fails under warranty and requires a replacement product to be found. We used in our model here only 1 additional day of downtime. I think, as many of you know from the field, that's a very conservative approach, where the average day, the average downtime for a product that is found to be DOA or fails under warranty might be many days, or even in excess of a week. And then lastly, we sought to understand where logistical defects arise from. So as you can imagine, you've got a broken piece of equipment. You run through the gauntlet of the fact that it's largely a manual, paper-based process. You find your way to that vendor after spending significant amounts of time, assuming you get the right price, which statistically doesn't actually happen that often, and make your way past, again, a gauntlet of quality issues. What happens if there are logistical delays as it relates to stockouts, long lead times, and so on? In our data warehouse, we see stockouts on average running 32 days. Again, here we made a very conservative assumption around products that are stocked out of an additional 1 to 2 days. And so what are the opportunities then, or what are the impacts to operations? And again, what we found here, similar to the quality work, is it's roughly 40 days per 1,000 transactions. What you see on this page is the average number of transactions that was in this large hospital sample size was 4,000 transactions per year. Again, that represents 110,000 beds in the country. So 4,000 is a decent number to use, and again, at 40 days per 1,000, you're at 160 days conservatively of additional impact to clinical operations. Now, many of us know that if you've got that happening on an infusion pump or something of that nature, you likely have spares and backups, and so the clinical impact may be negligible. But certainly there are plenty of products where the asset count across the health system or even within the particular hospital is quite lower. And so a logistical day caused by a stockout would be substantial, and the clinical impact and the clinical operations impact would be substantial. And so we found that, again, by looking through the information, there are ways to improve the quality coded return rates by using decision support, and importantly here, by understanding who causes logistical defects and how you can avoid that information. And so in summary, what we found was that the health systems we studied here, which were, again, 90 health systems in the US representing over 100,000 beds, were spending, when you looked at what the opportunity was within their organizations relative to what's available in the market, they were spending somewhere in the ballpark of 10 to 30% more for medical device repair and replacement parts than those who were best in class. They are managing on average 200 up to 700 and 1,000 different suppliers to perform this work, which is generally non-value added work, aside from the fact that that clinical resource, whatever it might be, a depot repair, replacement part, is of course required to get mission critical medical equipment back into the clinical care environment. They're spending significant time, on average 80 minutes, to source, track, receive, and reconcile that order. And those health systems without quality control surveillance tools were experiencing product defect rates that were 6 times worse than others. From these data, the initial information set and then the validation of it over the last number of years, we worked with a significant number of these health systems to identify the issues outlined in this study and conclude that really there were, first, many of them are avoidable, which was an important conclusion to the study, and many of them can be reversed. And so what we did at our business, PartsSource, was take an approach that, as opposed to what the company might have done 5 or 10 years ago, where it was really distributing parts or selling parts from lots of vendors around the country, we built a software platform that allows us to put all of the product first in one place with product information, pictures, and so on, to reduce the amount of time spent in product sourcing and product identification, and ultimately design decision support tools, design visual analytics, and designed team productivity tools that allow these health systems to work collaboratively to improve the order management time significantly. And I'll share with you some of the outcomes that have been gathered from hospitals who've participated in a program we launched in 2015 called PartsSource Pro. This is a managed service model where we partner with the health system to help them procure and deliver mission critical clinical resources to their end users, typically for in-house programs, although we do this as well with ISOs and with a number of health systems which have ISO labor, but rely on our parts program. And they receive our people, our processes, and our technology that we've applied to the problems outlined in this study. As a result, they've seen order entry, management, and reconciliation times fall 95%. They've used the decision support engines that we've built based on the highest quality and most reliable suppliers to see a 6x improvement in product quality related return rates. And so those folks have seen a quality related return rate fall under 1%, thus impacting additional down days that would have occurred by quality defects entering into their supply chain. And likewise, we've taken a similar approach on the logistics side. By using data science, we've identified those products which, although they flux every quarter, represent the highest stock out and long lead time products from all of the suppliers across the country. And we use the data from the hospitals we work with today, and we work with roughly 3,000 hospitals in the US today and over 15,000 clinical sites to look at their data, understand which products from which suppliers are causing delay, and we then pre-buy and forward stock those into our distribution centers. And as a result, we've reduced significantly the logistical down days in addition to the quality related down days. And then lastly, because we purchase in such heavy volumes across the country, we've been able to deliver 6- and 7-figure cost savings for folks who have medical device repair part procurement as part of their responsibility. On the right-hand side there, you'll see our methodology, which is really a lean process to understand where delay and waste occurs from the moment a product defect or need is identified all the way through its reconciliation. And we've broken this process down into a very detailed set of process maps that we use when we go on site to re-engineer clinical workflow and bring people onto our workflow and procurement platform. And we found that our people, process, and technology have really enabled these health systems to deliver top quartile performance across the U.S. I'll close here with some of the names of those folks that have been partners with us, and I'm pleased that we've seen great success in pediatric and children's hospitals, great success in small community hospitals like St. Clair Regional. We see great success across mid-sized IDNs like Allina Health, Piedmont Health, and of course large integrated networks like Kaiser Permanente, Intermountain Healthcare, Trinity Health, Mercy Health, and so on. And so in conclusion, I would say that we identified significant waste in time, cost, and quality in a process that almost every hospital in the country has to manage today, largely on paper or in fairly manual forms, that frankly is time that would be much better spent either turning wrenches or helping to work on the next great strategic program like cybersecurity or device connectivity. And ultimately, what we identified is technology-based methodologies to drive that waste out, to improve the cost equation, improve the quality equation, and significantly improve the productivity of teams that are tasked with this challenging but really critical task each day. Thanks for everyone's time. We'll open it up should there be any questions.
Thank you, Phil. We do have some questions coming in now, and just as a reminder, if you do have a question that you'd like answered, please look at your control panel, and there's a Q&A section where you can type in your question. So, Phil, first question that's come in, do PartSource Pro customers experience hard savings, reduced run rate expense, or soft savings, meaning cost avoidance?
Sure. So we're very specific to focus almost entirely on hard cost savings. What we've identified with our clients, the roughly 1,200 hospitals that have joined that program in the last 4 years, is an average hard cost savings of 8 to 10% off their prior year spend or same basket of goods spend. So not off list price, but off their actual spend. When you evaluate the soft cost savings in terms of additional time in the day for the clinical engineer, additional time for the manager who's doing approvals, additional time for the AP and finance staff, we think that when you do the math from the ground up and you apply, $45 an hour plus for the CE individual, the number of POs that have to be generated at $125 a PO, and we have all of that soft cost savings data available for folks. We think that the cost benefits are likely 2x or more what I stated a moment ago. So we think there's somewhere in the range of 20 to 25% savings. As I mentioned, the hard cost savings are often 8 to 10%. There are, as I mentioned, opportunities where our clients are saving 30%, 40%, 50% in those certain product categories that our data tells us it's safe to make the product switch, and the hard cost savings are really significant. And you have to, unfortunately, have both pieces of information to make the right recommendations to clients. But just this week, we were reviewing a number of those opportunities with a very large West Coast health system where there was an immediate $400,000 savings in a set of products that would have been very difficult to identify without the large data set. So yeah, we focus on that 8 to 10% number. We believe and have validated the soft cost savings are real, but we recognize the challenge in presenting that information oftentimes upwards to an organization. The good news is it often ends up being gravy, because 8 to 10% today, when you don't have to take bodies out and you don't have to make product quality changes, is unicorn status. There aren't a lot of those opportunities in hospitals. And so the good news is that most of that gravy falls back to the clinical engineering and supply chain teams. So even if they're running that up the flagpole even if they don't get quote unquote credit for it, most of that benefit accrues to themselves in the form of additional time in the day. And that's ended up being a huge win for our clients, not just the hard cost savings and the soft cost savings, but finally having visibility over where all of the spend is going, how to optimize it in future years, what I'm really spending to maintain my capital fleet, and so on.
Thank you. Another question came in. Did the study provide an average number of medical devices per bed, or did it provide an average parts cost or service cost?
We had the bed count data, and we did not collect the average number of medical devices per facility. More recently, we've begun collecting asset lists that would allow us to correlate that, but in the initial study, in the initial data collection, we didn't request that information. It's a great question to understand and begin to break down, average support cost per device and so on and so forth. But we've only recently begun gathering that information, mainly because our clients are now interested in associating things like asset ID, which we capture now as part of our integration to the ERP or to the CMMS, and we begin to provide them back asset ID-based costing, again, at an individual asset ID basis or at a product category, product modality basis. And that obviously has significant impacts to understanding cost to serve ratios and long-term dynamics around part pricing and part price inflation year over year. So those are the kinds of data elements that we're providing folks now, but wasn't an initial element or variable that we collected.
Given the data, what is the first thing you would do to make a quick impact for a health system?
Yeah, I would just say that, we're strong advocates, obviously, of defining priorities for what you're going to choose to be great at. And as we've had the privilege of working with fabulous partners around the country, and while we see great things at partners like Kaiser Permanente and Mayo Clinic and others, we also see great things at small regional community hospitals. And so what they've done is prioritize their work and said, look, I don't have the capacity in my day or the capacity in my team to do certain things the very best way they can be done when I'm being challenged to do a cyber security project, or I'm being challenged to do a new hospital acquisition or integration. And so regardless of who they choose as a partner, we've seen top health systems decide that having a clinical resource management strategy, i.e. finding a partner to help procure and logistically support the clinical resources coming into their facility, is really paramount. It should be a top priority, and across the large health systems and even the small health systems that have sophisticated approaches to how they're managing clinical engineering, we see those folks all have a partner. We're fortunate to be the partner of many thousands of hospitals around the country. But if it's not PartsSource, we'd encourage you to find someone who can help you be great at this and who brings evidence and outcomes data to your process, that brings you best practices, that brings you process reengineering, that brings you enterprise level visibility to all of your data, that brings you supplier performance metrics on every one of your suppliers, that brings you the ability to leverage the community-based buying power and buy more efficiently, more effectively. And we found that to be really valuable, from the smallest community hospital to the largest regional IDN. Every single one of those hospitals, we've been able to save hard dollars. So I would say find a partner. It's a strategic initiative for health systems to be able to find time and capacity and money and work on other initiatives when this one is an area that we found anyway, the processes and the technologies and tools attached to it are insufficient to reduce and avoid waste that they're incurring. So that would be one of the areas that I would encourage folks to strongly decide to identify a partner, or whether that's PartsSource or someone else.
Another question, Phil. Do OEM service offerings have an advantage for high-end devices, imaging, lab, et cetera, because of advanced training and direct access to parts?
Sure. I think there's a number of factors that go into deciding whether an OEM service agreement is the right decision. Obviously, folks need to appreciate the capability of their staff today versus the capability over the next few years. And obviously, there's many effective training programs out there. While some OEMs have made it more difficult to get direct access to training, there are lots of venues. We just recently launched for our PartsSource Pro members access to specialized training courses that we've identified that represent very high quality and very cost-effective solutions. But that's a 6-month or 12-month game plan to establish those resources if it can't be hired indirectly. Obviously, geographic access could be another question. So do I have the ability to recruit if I can't train in my particular geography? Are there high-quality alternatives, i.e. non-OEM based service providers? This is another offering that we provide our clients, which is providing them access to our quality database to help find high-quality non-OEM options, just as we offer high-quality OEM options. I think our perspective is that choice is most critical and most important here. But ultimately, questions of capability, capacity, geographic proximity, and then ultimately what a long-term capital asset management strategy is. Is this going to be an asset that you're going to have in place for a long, long time, in which case, that's probably something you want to train on if it's going to be a product you're going to support for many, many years. Likewise, if you're running off that asset, does it make sense to train on a CT from a brand name that you're going to be moving out of your facility? Probably not. It's worth a short-term CE contract. So I think it's a complex question. There are a lot of factors, but we believe that in this era, folks are going to be pressure tested to find non-OEM alternatives, more hybridized agreements, and more self-service. And we're working with our clients to prepare for all of that. And in many cases, the OEM is a good answer and is the right answer. But in many cases, there's good discovery work that should be done. And for those interested, we've done a lot of that discovery work for folks already and can probably save folks some time if they're looking at an OEM versus non-OEM service agreement strategy.
Another question, do PartsSource Pro customers implement at the enterprise level a formulary approach, or do they do it at a regional or facility level?
Sure. So most recently, and upwards, I would say up to a year ago, we would review with clients their own spend data to support their clinical asset fleet. And we would show them, based on the data warehouse information that we had, products that represented the same quality at a lower cost point if they were available in the market. The struggle and the request that came back from clients was, this is great information, now I know, but help me do something about it. And so what is a scalable, reproducible process that I can implement? And so this idea really came from our clients, which is used, as many folks on the phone will know, in lots of other places of the hospital. So formularies are used in the pharmacy, they're used in the surgical suites, they're used all over to determine really what our product standards going to be. Now, of course, you have to know what products you want before you create standards. And so we help clients evaluate the products they're using, evaluate if there are alternatives, or if the OEM products make the most sense. But sometimes it's driven by availability. Sometimes it's driven by lead time. And so we help them design and then deploy formularies really at a number of levels. Typically, I would say it's most often done at the enterprise because that really maximizes impact. You can imagine identifying 27 different product categories with 300 different products that represent better alternatives. And that might represent $400,000 or $500,000 worth of savings for a hospital. But how do you actually create change? You can't do team meetings, you can't do sticky notes for that kind of complexity. So we go through line by line, we programatize that into their custom catalog and custom engine. And those options are then expressed, the very next morning across the entire health system. So while it can be done at a local level, at a regional level, we typically see it being done at enterprise level. You'll often find there's greater sensitivity around OEM only within particular modalities like respiratory care, or in particular care environments like pediatric or NICU. And so we're able to go down and set those preferences at the site level if it's a requirement, or even at a sub-site level on a NICU floor where they only want to maintain OEM only options or non-OEM only options. So we're able to handle that based on different clinical care environments.
Another question, do you have or are you planning to have a customer review tool for your customers to provide feedback and opinion on their perception of parts and service?
So in the last year, we deployed feedback platform at PartsSource, if that's, I want to make sure I get the question right, but for our own company, we deployed a process called NPS, which stands for Net Promoter Score, and really seeks to understand feedback on every single transaction that we provide across the company. Now, we provide transaction level detail to our customers on every single thing that flows through PartsSource. Of course, the parts don't come from us, the parts come from thousands of suppliers around the world. But our job is to provide high transparency on every single transaction. And what I mean by that is, was it the most cost-effective option? Was it the option that represented the least potential for logistical delay, the least potential for quality impact? And we show our clients across their entire health system, every single transaction, the quality, logistics, and cost alternatives that were available. For our own service metrics, we use a concept called NPS. We've deployed a platform across the company. We began tracking this 2 years ago. We deployed a platform 1 year ago that allows us to have a consistent process for doing this. And it's interesting because obviously we're a customer service-based organization. We don't make parts. We help provide maximal clinical uptime at hospitals. But many of our own hospitals are asking what they can be using to get feedback from the constituents they serve, oftentimes the clinicians and end users on the front lines. And so we've evaluated a number of those packages. We ultimately selected one. If folks are interested in learning more about the approach we took to getting more real-time feedback from our clients and using that feedback to actively improve our business every single day, we're happy to share that information about what vendors we looked at and ultimately who we chose.
Okay. So Phil, we have time for one more question. What are other strategies you see clients implementing to improve cost and productivity?
Yeah, it's a great question. It's interesting. We were with a number of folks at one of the large government-based hospitals recently, and he said, I've evaluated what's out in the market, and what I need to do is find additional productivity in my team. I'm going to move forward on a PartsSource Pro relationship, and I'm going to move forward on an AEM, or alternative equipment maintenance strategy. And for those that are less aware, effectively that's a preventative maintenance schedule that may be different than what's proposed by the manufacturer, but one that the organization feels sufficiently produces quality results with a schedule that is produced internally effectively versus by the OEM. It still requires good documentation, still requires validation and so on, but ultimately it's about priorities. And I think both of those strategies are really smart because they're about prioritizing the work that needs to get done. In some cases, it is identifying lower value add PM programs and interventions. In another case, it's about determining what an organization is going to be great at. And again, whether that's with PartsSource or someone else, I'd encourage folks to look at a logistics partner on the parts side, and our business has moved from parts to now into on-demand services, into depot repair, into small capital, into rentals, into so many areas where hospitals have to quickly identify a high-quality provider of some form of clinical resource, a repair part to a rental to a service, and quickly get it to their facility to get that mission critical equipment back up and running. Again, whether it's with PartsSource or someone else, I think that's very valuable. And then likewise, looking at other lower value add work. And as long as you can validate it with good information and good benchmarking, hospitals are going to have to spend time looking at what the most critical areas to manage, their PM strategy. And we're seeing really strong adoption across our customer base. And in this upcoming year, we'll be actually launching, because of the interest in it, we'll be launching a AEM database that will provide effectively crowdsourced options, along with some industry experts that we've contracted to help us construct this, where PartsSource Pro members will have access to sort of the world's knowledge base around AEMs, seeing what others are doing and what results they've had, and basically, enabling the sort of cherry pick, both where are the high priorities and what resources do you have to share to let me get into that program quickly, largely just because we've seen such an outpouring of interest in both this and in the parts program partnerships to improve the productivity and cost of those organizations.
Well, thank you all for joining today's webinar. Phil, thank you for your time, and thank you for everybody who participated and provided some really great questions today. As a reminder, we will be sending out a link to the recording of this presentation to your email within the next 24 hours, and we hope you enjoy your day. Thank you.